Now you forget stuff. Now you forget why you are in your car driving to where you're going. You forget why you walked into this room. You keep misplacing your keys. You start to forget stuff. Why? Because this neuron right here that's responsible for memory is not getting a big enough signal. It's not being stimulated enough. So with Alzheimer's, the way that we have drawn it in this particular picture, now our signal is 2 millivolts, and now you can't remember very well. Okay? How can we treat it? Well, we can't get these neurons back. Once they're dead. They don't come back. There's no cure for Alzheimer's, but there are treatments for Alzheimer's. And this is just one treatment, by the way. What we can do, and by the way, tell me what this is called. What's that called? When the neurotransmitter goes back into the presynaptic terminal, what's that called? Reuptake. If we can keep the neurotransmitter out here longer, it will bind to these receptors longer. It will keep these channels open longer. It will depolarize the cell, okay, to a greater degree. So what we can do to treat Alzheimer's disease is give what's called a reuptake inhibitor. So what's the treatment? A reuptake, specifically an acetylcholine reuptake inhibitor. It is a drug, it is a pill that this patient will take, and that pill has a substance in it that slows that down. And so now the neurotransmitter sits in the cleft for a longer period of time, and so now the signal just got bigger. And I'm going to say that it's going to make the signal bigger by, I don't know, let's just say it doubles it. So now instead of a change of plus 2 millivolts, I'm making the number up, by the way. Now it's plus 4. It isn't quite plus 6, but it's bigger than plus 2. So without increasing the amount of acetylcholine in the brain, because we can't do that, some genius figured this out, figured out a way to increase the signal by keeping the neurotransmitter in the synaptic cleft for a longer period of time. Reuptake inhibitors is something I'm going to talk about over and over and over again for the next 50 minutes. Okay? It may not quite that long, but a good half hour. I'm going to keep on talking about it. All right? Are we good with reuptake inhibitor and how they work? You give somebody a reuptake inhibitor when the level of neurotransmitter is low. I didn't increase the amount of acetylcholine in the synaptic cleft. I just kept it there longer. But it mimics, okay, what does it mimic? Higher levels that are there. We can't do that. Okay? Yes, sir? Then it would be too much acetylcholine, and then you'd have some pretty severe side effects. Okay? So don't do so. You want to study for the exam, get a little bit less acetylcholine in your brain so you learn a little bit better. It doesn't work like that. Okay? There are side effects to these drugs. You don't want to give somebody a drug that they don't need. Okay? Because then bad things will happen too. Too much is too bad. We're not getting too much here. We're getting it to something tolerable so that they don't forget as much. This is a progressive disease, by the way. These drugs are not going to work forever. Okay, eventually the disease is going to get the person, unfortunately. And this is just one treatment. There are other treatments out there for Alzheimer's, not just this. Okay? Oops, are we good, guys? So that's acetylcholine. Now let's talk about some monoamines. And these are 3 monoamines that we're going to be discussing. We're going to start with serotonin because that's kind of the big dog of these 3. So serotonin is the feel-good neurotransmitter of the brain, although it's not just in the brain. Actually, most of your serotonin is in your gut. About 80% of it's in your gut. But we're going to concentrate more on serotonin in the brain. What does serotonin do? Well, it's excitatory or inhibitory, by the way. Know that, please. It's important in temperature regulation. Your temperature, 98.6 degrees, is helped by serotonin. Helps you sleep properly. Again, it's the feel-good neurotransmitter of the brain. The reason you feel nauseated, when you feel nauseated, is because of serotonin and a couple of other neurotransmitters that I'm going to mention. Has anybody here ever heard of Zofran? Anybody? You've probably taken it. Zofran is a serotonin receptor blocker. So, when you feel nauseated, part of the reason is serotonin is released in a certain area of the brain, in a synapse, it stimulates a neuron, and you feel nauseous. If you can keep serotonin from binding to its receptor, what do we call that, by the way? A blocker of a receptor, starts with an A. Oh my God, you guys are smart as hell. You're the best class you've ever had. Come on. A blocker is called an antagonist, right? So if you can block the serotonin receptors, Zofran is a serotonin receptor antagonist. And one of the main reasons that particular drug is prescribed is for people who have nausea. Okay? Are we good? Because that's what serotonin does. It's one of the things it does. It makes you feel nauseous. If you block the receptors, can stuff happen inside the cell? No. That stuff is causing you to feel nauseous. All right? Are we good? I want you to know that. Please, Zofran specifically. Or how we can treat nausea. Block these receptors. Vomiting as well. Now, let's talk about some abnormalities when it comes to serotonin. Again, as I said, feel-good neurotransmitter of the brain. When it comes to mood disorders, most often there's a problem with serotonin. And so when you have low levels of serotonin in the brain, it can lead to things like depression, generalized anxiety disorder, obsessive compulsive disorder, okay? And when I say depression, we're talking about clinical depression. When I'm talking about anxiety, I'm talking about clinical anxiety, not, the Indians lost last night, 9-2 to the Cubs. Okay, you're sad about it. That's not depression. Okay, clinical depression is where it's altering somebody's day-to-day activity. Okay, you're diagnosed with that particular condition. Okay, OCD, same thing. It affects your day-to-day life. Like, I'm very neat. If you go into my closet, you'd think I had OCD. I got my shirts are lined up just perfectly, my season, my color, my shoes are always nice and perfect. But right now, this morning, I was a little bit rushed. If I knew that my shoes were a little bit out of order, I don't give a shit. It's not bothering me my day. It's not going to affect me one little bit. But if I truly had OCD, and one of my obsessions was neatness in my closet, and one shoe was a little bit out of place, it would absolutely affect me the entire day. That's all I would be thinking about. That's OCD. Okay, a lot of people will joke, I'm OCD this, I'm OCD that, I might have to have my this and that just in order. You're not OCD. You're a neat person. You're an orderly person. Or maybe you are, who knows? Okay? But again, these are extreme conditions that are occurring. And it's epidemic right now, by the way. These conditions right now, they're at epidemic proportions. And I know that there are people in this room that have these conditions. I know it for a fact. Not because anybody told me, but because I know what the statistics are. There's just too many people in this room. There's too many, the number's too large for people not to have these conditions. Okay? Why? Why do these things happen? Why does a person not have as much serotonin? Usually they're just predisposed to it. They're kind of born with less synapses that are releasing neurotransmitter. Or the synapses that they have are releasing less neurotransmitter. And it can be environmental as well. So you can be wired like that and be susceptible to these particular conditions, and then stuff happens to you in life that then cause less serotonin to be released. So the Indians lost last night. For your Indian fans, you felt sad? You know why you felt sad? You didn't release as much serotonin. Your sadness was felt because the neurons were hyperpolarized and you didn't release enough serotonin to excite other cells. That's why you felt sad. But you probably got over it. Okay? So, and I'm not just talking about the Indians losing is going to cause somebody to go into a depression. There are lives occurring like deaths in the family, or just shit just keeps on going wrong on a daily basis, and it just makes you sad, and eventually it just kind of takes its toll. Why is it that some people can get over stuff like that, and others can't? We don't really know. Although we have an idea, and the idea is the person who does become depressed does get generalized anxiety disorder, does become an obsessive compulsive person, it's because that's kind of the way that they were wired. They just got unlucky. Really, in the end, is probably what it is. They're just more susceptible. I went through a tremendously bad time about 10 years ago. I was going through a divorce. I told you about my father-in-law, former father-in-law, who died and just died of cancer. My dad was dying of cancer. I was in a bad place, a very bad place. And I became very irrational. I wasn't thinking straight. And then something kind of catastrophic happened to me neurologically, and I diagnosed myself with a disease I thought was going to kill me. I was convinced of it. Absolutely nobody could tell me otherwise. I was not thinking straight. I was completely irrational. This can happen to anybody, guys. I felt that I was a very stable person. But when you got a whole bunch of crap happening to you in life, just one at a time, you start to get a little goofy. And so I went through a really hard time for about a year. But I came out of it, not depressed, not with anxiety, not with OCD. I came out of it just fine. At that time, I was depressed. At that time, I had anxiety because of all the stuff that was happening to me. I got lucky. I got lucky because I didn't develop any of these mood disorders, whereas somebody else could have just one of those things happen to them, and they have a mood disorder. It's just bad luck. A lot of times, that's just what it is. Now, fortunately, there are treatments for these things. So low levels of serotonin, any neurotransmitter in the brain, reuptake inhibitor. And again, serotonin is one that's typically targeted. And that's what an SSRI is, selective serotonin reuptake inhibitor. Prozac is the most prescribed mood disorder medication out there. Very well studied, very safe. Zoloft, Paxil, Celexa, Lexapro, there's a bunch of others out there. They all do the same thing. They inhibit the reuptake of serotonin, and then the levels in the brain are artificially higher. We're stimulating more. And by the way, the more that you stimulate these neurons, the more synapses they're going to make. Tell me what that's called. Make more synapses. Tell me what that's called. Synaptic. Starts with a P. Plasticity. Right? Synaptic plasticity is formation of new synapses. So now you have more synapses releasing neurotransmitters. That's why a lot of times when it comes to these medications that we're going to be discussing, it takes 2, 3, 4 weeks, even longer for them to work. Why? It takes long to develop enough synapses, to form enough synapses to then feel better. Yes? Doesn't mean anything. It means that just in that particular person it just does. Sometimes it's a placebo effect as well. Okay? So I want you to know that these reuptake inhibitors with mood disorders work through synaptic plasticity. That's how they work. That's how they think they work, by the way. So too does psychotherapy. What's psychotherapy? Going to a psychologist and getting therapy. It can be as simple as something like talking. Talking about the problems and the psychologist guiding you through your problems creates synaptic plasticity. I shit you not. There's studies that show. There's also cognitive behavioral therapy, exposure therapy. These are all psychotherapies. And you do each of these for different kinds of disorders. But a professional helps the person through different exercises, through different ways of thinking, and all of a sudden, they start to produce more serotonin because they have more synapses. Do we know exactly how that works? We do not, but it does. And the best way to treat is to do both at the same time. There are studies. And here's the other thing. A lot of people think that once you get onto these kind of medications, you're on it for the rest of your life. No, you're not. You might only need it for a year. You might need it for a couple of years. What if you do need it for the rest of your life? Okay. There's nothing wrong with that. People who are type 1 diabetic have to take insulin for the rest of their life. Is there anything wrong with them? Of course there's not. There's nothing wrong with somebody who has these disorders, but for whatever reason, these disorders are stigmatized. And you don't need, for no reason. The people who had these disorders did nothing wrong. There wasn't anything. They didn't take drugs, they didn't rob a bank, they didn't vote twice in the election, they didn't do anything wrong. So those of you that are out there right now who have these things, and you're not getting help because you feel desperate, you don't think that you're ever going to get better, I promise you, you will. I've seen it. Like, I didn't have any of this stuff happen, but there are people, deer